السلام عليكم ورحمة الله. السلام عليكم يا شباب ومرحبا بكم. Welcome to another video for SAIDA Personal and Professional Development Project. Today, Ahmed Adlan, a Senior Clinical Cardiology Fellow here in the UK, is going to talk to us about dealing with complaints. And without further ado, to you, Ahmed.
Okay, thank you very much, Dr. Ahmed. Assalamu alaikum. My name is Ahmed Adlan, and I'm a Senior Cardiology Fellow working in Manchester. And over the next 45 minutes to an hour, I'll be covering a very important topic about how we deal with complaints. When I was first given this topic, I was a bit concerned because I think it is a difficult area, but hopefully we will be able to gain from and benefit from the next this session. So I have no relevant disclosures or conflicts of interest. So the main objectives really is three parts really. There's three parts to this talk. The first is to understand the nature of complaints. Secondly, dealing with how to prevent a complaint. And thirdly, how to respond to complaints. So I've got a few assumptions about you who are listening in the audience, and those assumptions are that generally you're not involved in any criminal activity. Secondly, you have no bad intentions in your day-to-day practice and your life in general, and that you are all registered with the GMC. So let's start off with an introduction on complaints. So I think really the most important critical part of my talk is this statement that patient care is central to good medical practice. And I think you'll find that if you keep this in your mind every day in terms of your busy clinical environment, then you'll be on the right track. Now, there are a lot of quality control processes that exist to try to maintain patient safety. And I've listed a few of them here, things like governance meetings and risk management, DATIX, incident reporting, the use of quality improvement projects, an audit, and then formal and informal feedback. And this is something often that you invite others. So for example, MSFs and 360-degree feedback. And all of these processes are not complaints. And that's an important thing to bear in mind. So what is a complaint then? So the definition of a complaint, as we know it, is a formal allegation against a party. However, it's also an expression of grief, pain, or dissatisfaction. Who complains? Who are the complainants? Well, it could be your colleagues, your peers, or your junior staff members. It could be your seniors that complain against you, or other colleagues, for example, nursing staff. Also, patients can complain, as well as their relatives. Complaints can be informal or formal. You may have informal feedback to peers. It may well be that you will find that people will give feedback to the actual individual in question. This is less common, I would say. The feedback may go to the senior colleagues or even to your supervisors and managers. Then there are formal complaints, and datex, I've put datex in, although it's not technically a complaint. Often that you do find that there are complaints within it, but they can be patient complaints, for example, from PALs, or more serious complaints involving the GMC and medical tribunals. There's also criminal courts. So what are the causes of patient complaints? So in this study of 100 patients or cases, medical legal cases that were referred to a single physician back in the 90s, gave us an insight. Interestingly, around 44% of complaints, there was no serious clinical error. Sometimes it was because the person who's the patient complaining was just unable to accept the natural course of the disease or the risks of the procedures that they undertook, or commonly because they had a poor understanding of the disease process, and a small group of patients were just generally unreasonable, but it's a minority. Now, if you look over here, about a fifth of patients, there were preventable errors. And the main categories were that it was often there was evidence of poor teamwork in management of the patient. And in a small group of cases, it was because of poor judgment, and the clinician acted in a way that exceeded their competence. They did things that was beyond their level of competence. In around 15% of cases, it's actually an isolated error in otherwise good clinical management. And similarly, in about 15% of cases, it was due to actual carelessness or major incompetence. And then in a small but significant group of patients, the problem was actually, or the complaint was due to an issue with communication. So who was complained about? So the question here really for you is, what proportion of complaints were against junior doctors? Is it 5%, 10%, 20%, 50%, or 80%? Have a moment to think about that. And actually, it was around 20%. So 21% of cases were complaints against junior staff. And most of the time, this was the junior staff member was working alone. So the majority of the complaints, actually, these are serious complaints, legal cases, were against consultants. And in about a quarter of cases, the consultants were primarily or solely responsible. And in about a fifth of cases, they were aware of the problem, but not quite focused on that particular issue. So we're talking about serious complaints, and this is where GMC referrals can happen. So what happens after a GMC referral? This is data from the UK from 2018, and there's almost 300,000 registered doctors in the UK, and about 8,500 referrals to the GMC. That comes to around 3% of all doctors referred to the GMC. So it's a small number. The good news is that the GMC referral rates are actually falling over the last few years. Importantly, 2/3 of these referrals were from members of the public. The remaining were from organisations, for example, perhaps an NHS trust, for example. So what happens when you have a GMC referral? It's very serious, and there are life-changing consequences. And some people choose to even migrate. So I'm going to talk you through very briefly about what the actual process is once a GMC referral is made. So that's the first step. We call this an inquiry. GMC will then triage the case, and this can take up to a week, and they generally try to triage it very quickly. As a result of this triage, they may decide to do one of a few things. Firstly, they may actually go on and formally investigate, or they may refer back to the employer or the responsible officer. Remember, every doctor has a responsible officer, even consultants. And if there is an issue, they may refer back to that to your employer and with recommendations, or they may decide to completely close the case at the triage. In some cases, they perform something called a provisional inquiry, where they will gather some information and some more details to make their decision. And again, the outcomes are pretty much the same. Now, if they do decide to go for a GMC investigation, that will involve case examiners, and there will be 2 senior GMC representatives. Usually that will be 1 medical and 1 non-medical. And again, they can decide the following. They can either close the case with no further action. Okay, they can close the case but give advice to the doctor. They may issue a warning to the doctor, or they may agree undertakings with the doctor. So, for example, they may say you need to do X, Y, Z. You may need to do further courses, or etc. They may, in extreme cases, they may refer the case to a medical practitioner tribunal, and that's where it'll go to the court. And that's the MPT, the Medical Practitioners Tribunal. And this is where it gets extremely serious, because the consequences can be very drastic. So, for example, and very severe, the doctor may be erased completely from the medical register and lose the license to practice. They may be suspended from the medical register. They may be allowed to remain, but conditions are placed on their registration. Again, they may decide to agree undertakings with the doctor, or they may decide to give a warning to the doctor, or they may decide to actually no further action is required, and they will find that the doctor has been cleared of their charges. So actually, just to put this into context, so of the 8,500 referrals in 2018, nearly over 3/4 of them were closed, which is a large amount, really. So that means that only 1 in 7 cases of being referrals to the GMC are actually investigated. Okay. Now, in terms of once the investigation has happened, the chart on the right shows what the outcome is. So there were 1,208 investigations in 2018, and actually over half of those, the investigation was concluded, and there wasn't any. The case was closed. About just a fifth of cases were referred to the tribunal. Okay, which is very serious. And then you can see advice, warning, or undertakings were taken in those proportions. So, in terms of the Medical Practitioners Tribunal Service and GMC referrals, in summary, only 1 in 7 of the GMC referrals are actually investigated, and 1 in 30 of the GMC referrals are actually referred for a tribunal. Okay, so once the cases have gone to the Medical Practitioners Tribunal, and there were 247 cases, what was the outcome? So these on the left-hand side show the various different outcomes, And I just want to draw your attention to the bottom two, erasure and suspension, which are the most serious consequences. And 2/3 of cases resulted in suspension and erasure of the doctor in question. So the next question really is, well, who are at the highest risk of getting struck off? In other words, having been suspended or having an erasure. So there's actually some data about this, if you're interested to have a look, but I'll just summarize it briefly. Firstly, there are certain demographics who are at higher risk of being struck off. Being a man, being an international medical graduate, and having a longer time since your primary qualification. So if you've qualified your medical degree was more than 20 years years ago, then you're a higher risk. The mode of referral was also very important. So if the GMC referral was made from an organization, then the outcome was a lot more serious than if it was from the general public. Thirdly, the nature of the allegation. So allegations related to probity, relationship with patients, or if there is a concern about the doctor's health and ability to conduct their work, then these factors were more likely to result in being struck off. And then, importantly, the specialty also had a bearing. General practitioners and surgeons were at a higher risk of getting struck off. So I've given you some background about complaints, and there's some food for thought there. I'm going to move on to the second part, which is prevention. What can we do to prevent the complaint? Now, this is a diagram of an escalator, and you can see these bars, green, amber, and red. And the point really is that it's very rare for somebody to just make a complaint following an isolated incident. And usually what's happened is there is a series of events that happen, and that there's a certain threshold that's passed where that person will then it will then trigger them to complain. So there are certain actions that can be taken that can actually escalate the situation and make it worse. And then there are areas or actions that can be taken to de-escalate. And that's what I would suggest is that we try our best to prevent a complaint by preventing escalation of events, and also to promote de-escalation. So firstly, I would say to prevent a complaint, you really should read and adhere to the GMC Good Medical Practice Principles, and this guide is available on the internet, and I would recommend you to read that and follow the advice within it. Secondly, be courteous to your colleagues and to your patients. Take responsibility when you're at work, and work hard and smart. And thirdly, recognize the warning signs. In that diagram there was green, amber, and red. Well, we need to recognize when we're getting to that stage where the person is in the amber stage, and to prevent the complaint. And I would suggest we try to improve the patient experience as a whole, as well as our work environment. So these are the good medical practice domains. There are 4 domains, and there's a bit more detail on the right hand side, but I'll leave that for you to read in your own time. And I think this is an important point, that actually, if we're in a nice, pleasant mood and we're in a good, happy mood, and interactions are very positive, and we're enjoying ourselves and enjoying each other's companies, and you know, I think really we find that we're less likely to complain. And similarly for patients as well, we really should try our best to improve the experience for patients as they interact with the healthcare, particularly because they may have conditions which cause them serious concern and impact on their quality of life. So it's important for us to try to be positive. Taking responsibility. I think this is really critical to prevent a complaint, particularly as a junior doctor. If you're called, try to attend patients in a timely fashion, and if you can't, then warn your colleagues. Warn them to say, look, I really want to try to get to this particular patient, but I can't because of X, Y, Z. Then if you do warn them, then that will help the situation. I've put here, do your share of the work. You must put in the work. You must do your share of the work, and ideally you should be doing a little bit more than that. Being courteous is very important. Try to be positive. Do not speak ill of anyone, really. Maintain your professionality. And my advice is to avoid assumptions, because assumptions can often lead to more problems. So I would recommend to assume the best in people. Thirdly, perfect your craft. Focus on the quality of your work and improving the quality of your work. And documentation is very critical, because documentation may be seen as a reflection of the quality of your work. So the quality of your documentation may reflect the quality of your work. Documentation is also important because when investigations occur retrospectively, we often rely upon what's been documented. Improve your communication, both verbally and written communication. So whether that's at handover, or when you're presenting a patient on the ward round, or when you're writing a discharge summary or a clinic letter, always try to improve and perfect your communication. And lastly, identify and address your weaknesses. So do something, take action before it's too late, to try to prevent problems. Now, in terms of working hard, working smart, it's very important to know your limitations. I think that's for all of us. We all have to, whether you're junior or more senior, you should try to be aware of what your limitations are. Ask for help, senior review, and if you're ever in doubt, always check with a reliable source. There will always be somebody who's dealt with the problem that you're facing. So always do check with your colleagues. And I put there reliable source because don't take the advice from someone who's not reliable. Make sure that the person that you're getting advice from or getting help from is somebody who is going to give you the correct information. Because if so in other words, you don't rely on somebody else who may be incorrect themselves. And then there's a lot of talk about the use of chaperones and performing intimate examinations, and the GMC did provide guidance on this in 2013. And the question I have for you is, should you routinely offer chaperones for intimate examinations? Yes or no? Yes, the answer is yes. So the document, and again, it's available to read, and I would recommend you to read that if you are performing intimate examinations, is very clear that when you carry out an intimate examination, you should offer the patient the option of having a chaperone present wherever possible. And this applies whether or not you are the same gender as the patient. So this is important because it prevents complaints, potentially. And then it's important that we are able to recognize the warning signs before it's too late. So I've got some examples here. So firstly, when you're working and you're on your shift, do you get warm greetings from your other colleagues? Are people happy to see you? Or do they feel a bit distant or a bit cold? Do they feel a bit, disappointed that you're the person on shift? This is a warning sign. Something's not quite right, because it's very rare for somebody to come up to you to say, this is your issue, these are your deficiencies, we're not happy with this XYZ. Most of the time that doesn't happen. Try to compare the interactions you have with people with others. And I do this myself. If there's somebody who I find I'm getting a little bit sort of cold vibe from them, I look to see, well, how do they interact with others? Is it a problem they have with me, or is this just their nature, that this is just the way they are with everyone? Look at the relationships you have at work. Are you able to build relationships at work? And I mean relationships in terms of just friendly relationships, friendships. Do you find that there are a lot of confrontations at work? Do you feel that people are unreasonable? Do you find that people are reluctant to help you when you're overworked, or you find that people do not want to reduce your burden, or do you find that people actually do help you and offer to reduce your workload? Because if they don't, then that might be a warning sign. Do you find that people will bypass you for queries or questions? Will they not ask you, even though you're there, they may go and find somebody else to speak to, and that may suggest that there is a problem. You may find that there are some informal complaints to your seniors. Your SHO isn't responding to my bleep, so I called you instead. And then finally, it's important that we're able to recognize potentially difficult situations, because if we don't handle them correctly, they may well escalate. Now, there's this concept called emotional intelligence, and I would recommend that you read about this if you're not already aware of it. But it's essentially our ability to read into situations in terms of interactions with people, and to have an idea of what is a good action, what is not a good action in that particular situation. There are some people who have got very high emotional intelligence, and there are some who have low. And those who have low emotional intelligence may be more likely and more prone to being complained about. So here are some signs of a low emotional intelligence. So being argumentative, not listening, blaming others, and having emotional outbursts. Okay, these are signs of a low emotional intelligence. And this may suggest that you may not be aware of issues or problems, and you may actually end up escalating issues rather than de-escalating. So I've just got a couple of quick examples here, and the question really is, what will you do? So these are real examples. So a nursing staff member has called you about a patient who's been transferred from another hospital, and they need clerking. The patient's been on the ward for several hours and is complaining to the nurses that they haven't received their analgesia yet. The patient has now asked to see a doctor. So have a think about how you would approach this. So firstly, you should recognize, and I think we all would recognize, that this is this is a difficult situation. So my suggestion is that you should prioritize this task, and at the very least, prioritize getting the patient analgesia. So for example, you may prescribe the medications, checking that there are no allergies, and prescribe the medications, and then check there are no allergies, and come back for a full clerking. So for example, prescribing the analgesia and then coming back for a full clerking. You should see the patient. I would recommend to see the patient and apologize that they've not received their analgesia because it's not acceptable. Offer an explanation for the delay and explain what you will do to help the patient. And that's the critical part, is that you explain to the patient what it is that you're going to do now that you're here to help the patient. Okay. Second example, there's a patient who is critically unwell with multiple comorbidities and frailty. They're approaching the end of life, and they have been reviewed by a consultant who has decided DNA CPR, to not resuscitate, and ceilings of care are to be ward-based. The patient's family have arrived onto the ward, and they're demanding to see a doctor. They tell the nurses that they want the patient transferred to intensive care immediately. So what will you do in this situation? I think we all agree this is a difficult situation. So firstly, if you recognise that it's a difficult situation, well done. And this, again, you should prioritise this task. You should, my advice is to, again, see the patient, or if you're uncomfortable to deal with this type of problem, then alert a senior colleague and do that early so that they can come and sort the situation out. This is essentially, this boils down to breaking bad news, and you have to be aware of this consultation. And again, we mentioned about complaints are expression of grief and dissatisfaction. So good communication skills are essential in dealing with these type of situations. So it's very important that you try to practice and learn communication skills. So very briefly, I'm just going to talk through how I approach de-escalation. So firstly, make sure you have the appropriate setting and the appropriate time. It may be that you have to actually schedule a day or time, an appointment for these type of consultations. Make sure it's a quiet room and that you're not going to be disturbed. I always recommend taking support with you. For example, a senior nurse. Thirdly, make sure that you actually see the patient before you speak to any relatives. Check that they're happy for you to have a discussion with the relatives, and make sure you know the case very well. Make sure that you actually know the case very well. Don't get involved in discussions with patients or relatives when you don't know the case. Number 4, take a deep breath and prepare yourself mentally. And I do this myself. I pause and I think, and I let my body become aware that this is going to be a difficult task, and I set myself up. I try to clear my mind and prepare. So it's clear your mind and prepare. Preparation is very important. Prepare what you're going to say and how you're going to say it. Think about what your tone will be and your appearance, and make sure you hand in your bleep so that you're not disturbed. During the consultation, it's really important to be prepared to listen. And I think this is the most important aspect of being a doctor, is the ability to listen to the patient, the relatives, and the colleagues, so that you can really understand where they're coming from. Number 7, it's really important to empathize. And I know there's a lot of communication skills talks and courses that you can go on, and showing empathy is very, very important. And try to respond to their concerns in an appropriate and courteous manner. Even if the concern may not seem very big to you, it may be very important for that particular person. Number 8, at this stage, I then like to probe the patient's or the relative's understanding of their condition, because often, a lot of the time, issues relate to the fact that there's been some misunderstanding, and so I like to check what their understanding is, so then I can help clarify certain things. You have to remember, we are doctors, so we often we know things and we take things for granted, that particular knowledge. Number 9, then try to communicate the facts using clear, simple language. And I mentioned facts because I try to avoid communicating opinions. It's best to stick to the facts. Opinion, you can give an opinion, particularly if you're asked. So often I find that I give all the facts and I've communicated the facts, and then the patients may then ask me for my own opinion after that. So what do I mean by that? I mean, explain the diagnosis, the treatment that's been given, and what the plan is, and also some rationale for the decisions that have been made. Yes, emphasize the positives. So when I'm dealing with a difficult situation like this, I will try to emphasize to the family or the patient, look at the things that we have done so far. We are giving active treatment. We are trying our best. We're using all the medical treatment that we can use. We are making an effort. Number 11, recognize that there is a time and a place for problems to be resolved. So I will say something along the lines of I'm the on-call doctor, so I'm not the doctor dealing with your particular relative, but I will carefully document your concerns to make sure that they're passed on to the day team. And I'm sorry, I can't do more than that at this stage, as I have to go and attend to other poorly patients. You'll find that most of the time, actually, patients and relatives are very, very reasonable and understanding of that. And lastly, always have an exit strategy. You can't stay in these consultations indefinitely. You need to be able to have a plan of how you're going to end the consultation. So I will often I'll say something along the lines of, I'm really sorry, but I have to leave now. But if you think of any other questions or you have any other further concerns, then please let the nursing staff know, and we will do our best to address them. Okay, so moving on to apologizing. So apologizing is something which can be a little bit difficult, and different. There are different cultures approach the apology in a different way. So I would suggest there are 2 types of apology. There's the apologizing where you are not accepting the blame on the left, and the apology where you are accepting the blame. So you can say, for example, I'm sorry that this has happened to you, that you're diagnosed with cancer, for example. I'm not accepting the blame for that, but I am actually genuinely sorry for that. Or I'm sorry that this incident or my actions made you feel that way. It wasn't my intention to make you feel that way. And saying things like, I'm sorry this complication occurred, in the context that it is a recognized complication and the risks were communicated and during the consent process. The apologizing in terms of accepting blame, I think this is very important that we do this, and this, we call this duty of candor. So if we make a mistake, we should tell the patient and say openly, I'm sorry, I made a mistake. There was a breakdown in communication. Or, I'm sorry, your care was compromised. The test was delayed because I filled out the wrong form. And when it comes to great communication, it's difficult to teach, and you just have to observe it. So do your best to go round and be involved in these difficult consultations, and see how the great communicators that are out there, and there are lots of great communicators, how they deal with it. So the last part now is part 3, which is responding to complaints. So the first thing to say is I am not an expert in complaints, and I appreciate that there is more than one approach to anything, and a lot of them, they're all valid. But I think the most important advice I can give anybody is to think before you act, because you're going to have disastrous consequences if you don't. Now, the complaint may well arrive from PALS, and in fact, I do actually refer patients to PALS because they're a very good service for dealing with patient complaints, and they do offer patients a lot of support, and they're able to get the complaint dealt with as quickly as possible. So I would definitely recommend not to shy away from the PALS. So I suppose my approach really is to try to clarify what the nature of the complaint is. Okay, so you've had a complaint against you, you want to try and work out, well, actually what's happened here, so get all the facts, do your own investigation, find out, look at the notes, find out, look back in your diary, look at what the situation was, try to get all the facts yourself. Whenever you get a complaint, it's important to respond in a timely fashion. So the more prompt you are at responding, the better usually the outcome. So do warn them to say if you anticipate delays, so say, listen, I'm going to look into this complaint, but I need to get the notes. So I've requested the notes and I'm waiting for them to arrive. And that's something you can tell even the patients or the relatives. It's very important that you seek support from your family, from your peers, from seniors. You may need to get a second opinion, someone who's not involved in the case, or even legal opinions. So your responses can be written, or they can be via a discussion. So, for example, you may want to invite the family or the relatives or the patient to sit down and to discuss the complaint and the issues in a quiet room. That may even be on the ward or in the clinic. You may arrange a clinic appointment to discuss the concerns with the relevant people. I would always acknowledge the concerns that were raised, and acknowledge any errors that were done. So I would acknowledge that. I would try to offer an explanation for why that particular event happened, and what you have done and what you will do to ensure that it doesn't happen again. I think this is an important point, because a lot of the time when you think, why do people complain? Well, a lot of the time they may complain because they just don't want somebody else to go through the same thing that they've been through. So if you can offer those reassurances, it's very useful to do. And that's also important because the complaint often is highlighting that there has been some breakdown somewhere. So you want to ensure that you do prevent it from happening again. Now, actually, most of the time, as I've shown you, I've shown some data earlier that the reason for complaints is that there's a misunderstanding about the disease process and or even the treatments that are given. So I do take the time to check their understanding and to explain to them, and even sometimes you may say to them, well, listen, why don't you get a second opinion? If you're not happy with the decision that I've made, a clinical decision that I've made, then I'm very happy for you to go and seek a second opinion about your condition. And that's a very valid thing to do. And you may find that actually they go and see somebody else who gives the same opinion. But again, that's that's very useful. When you're communicating with patients and relatives, use simple language. Avoid too much medical jargon. Okay. Explain the facts of the case. So rather than talking about well, I think giving an opinion is important, but try to explain the facts of the case first, and avoid any emotive or defensive or accusatory comments. So don't say, I'm really disappointed that you complained, or I'm very upset by what you've said. There's no need to mention that. Just explain, answer the complaint, explain the facts of the case, and avoid these type of emotive language. If you're unfortunate to be referred to the GMC, then at this stage I would strongly recommend that you seek legal support from the medical defense organization, from the BMA, or even from a private legal advisor, and I think that's very important to do. I think the second thing that's really important I would suggest is to comply with the policies and investigations of the GMC, and whatever they ask of you, make sure that you do comply with it in a fuller sense that you can. I've shown you data to show that actually a large proportion of GMC referrals are dismissed, even at the triage level, and even following their investigation. Okay, so do remember that. Thirdly, engage with the process and respond to the GMC with empathy. Reflect on the case, reflect on the situation, and demonstrate that you're doing something, that you've recognized it, and you're not just ignoring what's happened, that you're responding with empathy, and you follow any advice or recommendations that they give you. Okay, so do not be in denial, and this goes down to emotional intelligence as well. So reflection, and I think reflection is very important and is critical in dealing with complaints. And I've put here that you should carefully document the complaint in your portfolio or your appraisal. And I say that because there is a section that does ask about complaints. So it's something that you are obliged to document, but you should do this in a very careful manner. And my approach would be to just put down a brief summary of just the important facts of the case, very, very brief, and then focus on what you have learned from the case, what have you changed in your practice, and what learning deficiencies have you identified, and how you will address them. So, for example, it may be that you've got a deficiency in a particular, management of this particular condition, and that you will address them by going on a course. Or you may have issues with deficiency in breaking bad news and communication, so then you will go on a course on communication. I think the image on the right, I think, is very important, is that when we're reflecting, my take on reflection is that we should focus on, so the art of good reflection is not to focus on who you were, but rather who you would like to become. Now, I've just got these two perspectives of complaints. One from a patient on the left, where they made a complaint, it was dealt with very swiftly and promptly, and actually they were very happy with the response of the complaint. And on the right-hand side, there is a statement from a retired hospital clinical director who does acknowledge that complaints are very common, and often they are valid and straightforward. But sometimes they may be, patients may be, or the complainants may be unreasonable. So in conclusion, GMC referrals are common, but a minority, number 3%, are actually referred to a medical practitioner's tribunal. When it's referred to that stage, it appears to be actually quite appropriate because most of those cases have serious consequences. Remember, there are risk factors for being struck off. Some of these risk factors are things we can work on. Some of them there are things that we can't. In my opinion, prevention of complaints is critical. And if you always make patient care the main focus of your work, then that will help you to prevent it. Read the GMC Good Medical Practice, work on your documentation, and recognize the warning signs. De-escalation. If you're a junior, remember to seek senior support and know your limitations and document very clearly. For those who are senior, respond to complaints appropriately in a timely fashion. So I'd just like to finish with this image and to say that a mistake can occur in an otherwise exemplary record. So thank you very much for your time, and I'm happy to take any questions.
Thank you very much, Ahmed, for today's presentation. I can start off with questions if that's okay. طيب ناس سودانيين يعني الدكاترة السودانيين شغالين هنا في اليوكي، هل نحن في increased risk بالنسبة للcomplaints ولا ما بيننا وبين
That's a good question. So the question is Sudanese at a higher risk of having complaints or GMC referrals? Well, actually, there was some data on this, and Sudan wasn't among the countries. So there are some countries which they seem to have the higher rates of GMC referrals, and there are a group of countries where there is a lower risk of referrals, but Sudan is not on that list. But overall, if you are an international medical graduate, then that does put you at a higher risk.
Thank you very much, Ahmed. There is a question here as well from Hazim. Can portfolio reflection be used against us, as what happened in Power Garba case?
Okay, so as you probably can tell from my talk, I avoided going into specific cases because I think specific cases should be allowed to be dealt with through the specific channels and the investigations. But I think that's a very good question. That yes, documentation can be used against you in terms of even reflection as well. So yes, and I mentioned in the talk that you have to be very careful in what you write in your reflection, and I think I tried to clarify the approach to minimize the risk of that happening.
Okay, thank you, Ahmed. One more question. There are different defense unions and indemnity schemes with different kind of subscription kind of fees for all of them. So very kind of significant difference in the term of service that they provide in case of complaints, especially for GMC.
So I think that the two commonest ones, the MDU and the That's the Medical Defence Union and the Medical Practitioner Society, MPS. They're the two commonest ones that I have been aware of in my practice, and I don't think there's much difference between them. But I would say that if you are getting to the stage where there's a serious complaint, for example, a GMC referral, then my recommendation is to get additional legal advice as well as that. They do offer legal representation, but I think my advice would be to go for something private as well.
Thank you, Ahmed. And when is the best time to contact the defense union or the indemnity scheme or even the private lawyer? Is it as soon as you get a notification about the complaint, or is it a bit further down the cascade of investigation?
So I would say, I mean, if you're talking about a complaint, just a complaint in general, then I wouldn't necessarily involve the MDU or the MPS or any of these organizations for just a complaint. I think I would, speak to your supervisors, and often, actually, to be honest with you, as a junior doctor, as you've seen in the data, that around 80% of the time the complaint is against the consultant, nothing to do with the juniors. So you often find that the consultants actually often will deal with the complaint on your behalf. As long as you are open and honest, and you help clarify the facts of the case to the consultant, and ensure that your documentation has been very good, and ensure that you're the type of doctor they'll look at and say, well, actually, this person has an excellent record, and yes, there may have been a mistake that was made, but otherwise the care has been very good. So I think for a complaint, I wouldn't involve. Now, if you're talking about a GMC referral, okay, then I think things are a bit more serious in that situation. And as I've shown, the processes is that most of the referrals to GMC are closed at the triage stage, so they will be dismissed. So let the GMC do their triaging, and they've mentioned that it takes about a week to do that, and after that week, then they make their recommendations, and they may then decide to actually investigate. And I think if the GMC are deciding to investigate, then at that stage I would definitely get legal representation and involve the your MDU or the MPS.
Thank you, Ahmed. And different trainees have different styles of learning. Certainly, most of them kind of learn by making mistakes. So, kind of the fear of being sued or getting complaints should kind of hinder the search for training opportunities, or people should be more careful about even dealing with difficult cases, or is it something just part of the process, and we as trainees we shouldn't kind of worry about this and ask consultants or so to deal with the problems and then take it from there.
So in terms of so if you just repeat the start of that again, the start of the question.
So as trainees, we are learning different, there are different kind of learning styles for people. So some people learn by reading and just seeing new cases and difficult cases and making mistakes, and then learning from their mistakes.
Yeah. Okay. Yeah, I think the era of medicine has changed, and I think the earlier generations, a lot of medicine was learnt by you practice. You get a license to practice, and then you do your best and you practice. And knowledge was limited, experience was limited, and understanding of disease and interventions were limited, and availability of expertise was limited. So yes, I think in the past you would often have to learn from your personal mistakes. I think now that's changed a lot, and I think the focus now is actually we have to learn from others. Number one, learn from the mistakes of others, because communication has improved and there's a lot of knowledge available, a lot of courses available. So that's the first thing. And I think the second thing is that that we, even in my own training, I found that we're not allowed, given the free rein to just practice, and it's done under supervision. We have to, everything that we do, I'm talking from an interventional perspective. So we often have a lot of the medicine is heavily supervised by consultants, for example. So even when you're training and trying to learn interventional procedures, for example, you'll find that you're not going to be left to it alone. You're going to be watched. You're going to be learned. You're going to be trained in order to gain the appropriate skills to minimize complications. And I think this is very good, because patient safety should be the most important, and more important than doctors' training.
Thank you, Ahmed. One last question. You mentioned at some point during your presentation that the complaints can be affecting some individuals to the degree that they end up kind of struck from the GMC and they end up migrating to other countries. Are they going to get good standing certificates from the GMC for the period they worked here, or only going to be considered as well, and they have to start from zero in the new countries?
Yeah. So to be honest with you, I don't know that specific answer. I don't know how the GMC, whether they will give you that, if you leave, and if you leave the country, and if you don't engage with the process. And actually there are a group of people who they do not engage with the processes of the GMC, even when it gets to the serious state where it's referred to the medical tribunals, medical practitioners tribunals. And I think this is a shame to do that, because that automatically will mean that you're going to get the harshest of punishments. But again, it's not my place to say what the right thing or the wrong thing to do. It's each person has to do what they feel is right for them. But my approach would be that if you want the best chance of getting a good outcome, then you should engage and accept that there may be some restrictions, or there may be some conditions on your return to work, or it may be that you may not be working in the same type of place you were working before, for example. But I think my advice is to engage with them to improve your chances of having a better outcome.
Thank you, Ahmed. And Arwa Babi is asking, does RCA also considers as a form of complaint? I'm not sure what's RCA is.
Yeah, so RCA in cardiology is the right coronary artery, but actually I think they're referring to root cause analysis, and this refers to a way of investigating a problem. So when you have a problem or a complaint, you want to try to work out what was the initial cause and the root cause of the complaint, and it involves going backwards and taking steps backwards. I think that the root cause analysis is a way of dealing with any type of complaint, but I don't think it's necessarily a form of complaint, but it's a way that we can investigate complaints. We can use them for DATEX as well, incidents, even if it's not a complaint.
Great. Thank you very much, Ahmed. And thank you very much for the much needed presentation today. And hopefully, as you said, prevention is always better than cure. So people can benefit from this, inshallah. Thank you very much again. Thank you for all the audience and all the interaction in the comment section. Thanks.
Okay. Thank you very much. Take care.